question. As Mark said, we welcome the opportunity to share with you something of how the system works and something of some of the more recent developments that we've tried to put in. We had a little conversation before the meeting started, and as people were quite right to point out, we are entering the winter period. I think it's fair to say we can probably all remember when traditionally the rest of the year had a certain characteristic, and winter it got noticeably busier. And it's fair to say, that in more recent years, winter is more around a change of characteristics in terms of the presentations that services tend to see. Yes, in the busyness, but also in terms of the types of illness and that people are generally poorlier around the winter time, and so there's an extra sort of special consideration. Can I just pause for a minute and just place in the chat if you can't hear me, because we did have a couple of technical gremlins just at the beginning. If you could just let Mark know by placing in the chat if you're struggling to hear. No, that's great, thank you. So what we're going to do with this session is provide you with an overview of the emergency and urgent care services that are available, and we're going to just briefly showcase some of the more recent developments and improvements that we've designed and implemented in terms of hopefully making services easier to access and provide an enhanced quality of care for our population in Derbyshire. The urgent care system traditionally, in the media, the headlines tends to be around ambulances and acute hospitals and things. And so it's really important to remember that we're talking here about the whole healthcare system, and that from 111 through to local pharmacies, of course hospitals, GP surgery, all those different places that deal with planned care and unplanned care, which emergency and urgent care is. And so there's obviously from the service delivery point of view, there's a huge interrelationship between all those different services in terms of unplanned care and planned care, but also in terms of how those colleagues and those organisations and those services link together to hopefully provide a service that's easy to access, easy to understand, and supports people where possible to receive care as close to home as they can and as conveniently as they can at the time that they need it. NHS 111. We're broadly speaking, we'll sort of talk about the patient journey, if you like, if you put it like that. So NHS 111. What I'll do actually is draw your attention to the bottom of that slide. So traditionally, we all think of NHS 111 as a telephony service, and indeed it continues to be a telephony service. And NHS 111 aims to provide a whole suite of systems so that not only can a patient understand better and more often than not be reassured and a plan can be made, but NHS 111 also has access to those other points of care in many cases, so that rather than just giving telephone advice and the patient or service user sort of hangs up and goes away and has then to in effect start again and enter different systems, gradually and over time via a mechanism that's known as the Directory of Services, NHS 111 is able to either signpost or in many cases make firm arrangements or appointments for patients to go to whichever service is most appropriate for their care. And I think, although it's at the bottom of the slide, I will just draw attention again to NHS 111 online. Of course, we completely acknowledge that not everyone has reliable access to internet and devices that support that. But where possible, the feedback on using 111 online is really good. So I would encourage people to use 111 online, perhaps in the first instance. But of course, the telephone service is there for those people who find that more convenient or who have specific needs that they think would be better addressed by using the telephone. local community pharmacy. Now, local community pharmacies, of course, informally have long been a source of important health information, of health advice that supports some of the therapies and products that they sell, and also in terms of their advice when giving prescriptions and things. So they're well established within our local community, and obviously they're often linked to they're near the GP, so that people can access those two services hopefully relatively conveniently. Obviously, pharmacy is available at various times of day and on most days of the week, certainly within a geographical area. Some of the pharmacies operate rota systems, and obviously in areas such as the supermarkets and other local pharmacies, they're available late into the evening and at weekends. More formally recently, the NHS has enabled pharmacies to deal with some of the more common conditions that people experience year round. And some of those are listed on the slide. So they include colds and coughs and skin infections and sore throats. And via different mechanisms, sometimes because those pharmacies are independent prescribers, and sometimes because they work off protocols, our colleagues in pharmacy are able to prescribe and supply the medications that in some cases are needed. Of course, it's important to point out that many common illnesses and ailments actually are caused by viruses, and so the solution may not be to resort to medication, or maybe to use an over-the-counter medication rather than a prescribed or a prescription-only medication. But of course, what that does is it means that patients then don't have to get the opinion of the pharmacist, and then, in addition to that, see a doctor or other clinical prescriber in order to access the medication that the pharmacist has advised them in the first place that they need. Urgent treatment centres. So urgent treatment centres are available throughout Derbyshire. Of course, it's not lost on us at all that Derbyshire is a mixture of urban areas and rurality, and that sometimes, especially as the winter weather takes place and bites, that sometimes what looks easy on the map, it isn't always as easy, and sometimes people may go to somewhere that's not closer because in effect it's easier to get to. So again, if you call 111 and the outcome, as we call it, or the disposition, is that your care will be best dealt with by an urgent treatment centre, then 111 more often than not are able to make that specific arrangement for you and arrange a specific time for you, so that your delays, and it helps patients and their relatives plan, and it means that you're delayed less when you actually go to the urgent treatment centre. Of course, you can walk into a treatment centre if that's more convenient, and of course, as you'd expect with every sort of accident and emergency department or urgent treatment centre or in most healthcare facilities, appointments are made, but obviously some of those services have to deal and have to prioritise to keep people safe when they arrive. And so we just ask for that little bit of flexibility for those units. But generally speaking, the best way to access timely care at an urgent treatment centre is to call 111 and get that appointment slot. But they're open at least 12 hours a day, every day of the year, and urgent treatment centres are equipped to deal with many of the common ailments and or injuries that are commonly experienced. And this map just shows in a little more detail and a little bit more pictorially where our urgent treatment centres are located and the hours that they're open. Now, obviously, again, we briefly mentioned this with those friends who joined slightly before the call started, but this is a time of pressure on services and often a time of sustained pressure. And obviously there are lots of messages, including My Last 10 Minutes, where we advise of the alternatives to emergency services, as in the ambulance service or in going to the accident and emergency or emergency department. It's really important to say that the reason we do that is to preserve those services for those patients who really need them, so that those patients who really need them have a better chance of having timely and prompt and, where necessary, immediate care. And when you work within those services, the risk can be much better managed if the patients there are sort of not overwhelming the services and things. And so it's really important that, despite everything I've said, please know that if you have an emergency or a life-threatening situation, 999 or emergency departments are there for you. Please do not think that you're being a nuisance using them. Please don't think that you shouldn't do, or that other people need them more. If you think you experience a condition, so severe chest pain, if you think someone's having a stroke, using perhaps the fast guidelines and things, 999 and ED are there for you. And everything that I'm talking about today is designed to preserve those services for those people who need them. Various campaigns over the years, and again, the message evolves. It takes into account the technology and obviously the sort of prevailing disease patterns or illness patterns. But essentially what the public campaigns aim to do are to get people the best care as quickly as possible, focus on keeping people well in terms of the right, keeping like long-term conditions well, using 111, using urgent treatment centres. Also preventative steps, so keep well. Please get vaccinated in terms of routine childhood and adulthood vaccinations. Seasonal influenza and COVID vaccinations are ready available for patients with vulnerabilities, and again, they're available either via your GP or on the NHS app. And again, for those of us who do have access to technology, the NHS app takes a little time to set up in terms of proving your identity and all that kind of thing, but actually it's becoming a really great hub of information and access in terms of making accessibility easier and information. So I'd really encourage people to use the NHS app, and with that, as with anything like that, it develops over time and will continue to develop into a better product, I'm sure. The aim of everything is to reduce pressure on services, but the aim of that is to provide a better service and better quality care for patients. And I think one of the other things is just to encourage ourselves, our families, those we know, just to develop something of a plan for what you would do in a certain scenario with a certain illness if it was a certain member of the family. So appraise yourself of what services are available, and have a broad outline in your mind of who might look after people, who might look after children, how you would get there, which service you would go to. And sometimes just that little bit of pre-planning helps avoid the sort of services of last resort, as in the emergency departments and the ambulance service, and helps us sort of appreciate what's there, but also, as I say, when to resort to those emergency services when they're needed. So delivering improvements. I've probably talked about this already, in all honesty, in terms of the 111 piece. So 111 online, I would encourage everyone to make themselves familiar with that and use it. In terms of organisationally, though, the most recent development is that the NHS across the Midlands, and that's a huge area, that's sort of from Shropshire in the west and over to the Welsh border, right over to the North Sea, essentially through Lincolnshire and Nottinghamshire, and in the West Midlands as well. So that's now a single 111 contract that's provided by Derbyshire Healthcare United, and so that contract is able to bring more scale in terms of expertise and of knowledge across the area in terms of, so obviously some patients, just because of where they live, they may get some of their care outside of Derbyshire. So if you live on the borders of Derbyshire, say into Staffordshire or Nottinghamshire or Greater Manchester, it just means that there's that scale that enables our colleagues in 111 to bring a bigger suite of services and a bigger suite of advice, but also knowledge of cross-border issues and a consistency in service. And that new contract started in April of this year. Pharmacy First is the NHS name for the initiative that I touched upon earlier. And as I said earlier, essentially what Pharmacy First does, it enables and empowers pharmacists to supply the medication and a care plan for the common illnesses and ailments that you see in the green section of the slide there. You don't need an appointment. You can. Every pharmacy now has a consultation room where you can talk about things that you wouldn't necessarily want to talk about in the middle of a busy shop. And so, please don't be afraid to request that. I know within a pharmacy, commonly, you do hear people giving their name or confirming their name and things. Please don't be frightened to ask to use the confidential consulting room where you can discuss your ailment or an indelicate insect bite in the confidential surrounding. And again, urgent treatment centres in 2003, the procurement service they were reprocured, and those to reflect more formally those links between diagnostics and pharmacies and primary care with our general practice colleagues. And this slide particularly talks about the urgent treatment centre in the Derby city centre. There is still the urgent treatment centre at the front door of the emergency department at the hospital, but this is an additional facility that links in more closely with those diagnostic pharmacy and primary care services that we're talking about. And again, the idea of that service is to grow and to develop so that it becomes more of a sort of hub, and so that patients can be signposted without having to go to other services. Working with our ambulance service colleagues, one of the nationally there are real drives to provide alternatives for our ambulance colleagues and for the patients who they serve to go to the care that they need. And sometimes that's by remaining in your own home, in terms of the ability to quickly access services that support you to remain at home, or that provide specific service, or to go to specific services that aren't the emergency department. Now, obviously, there's a little trade-off there, because from our point of view, we want the best quality of care for patients, and we don't want patients all descending on a sort of single point, which is the emergency department, where we know, for all the reasons that we've discussed already, we know that sometimes it can lead to long wait times and everything that goes with that. And so very much we want people to be directed to the care that they need at the point where the expert paramedic and other ambulance colleagues are with them and have done a full clinical assessment and decided that in consultation with the patient or with whoever's with the patient in terms of their family or other clinical professionals that might be on the scene of the ambulance call, that actually a better plan is not to convey the patient to hospital, but is actually to put in place one of these other readily accessible services. And to support that, we've developed a local navigation hub that our ambulance colleagues can contact as a single point of contact, and then those services can be accessed and set up. And we know that as call before convey. And obviously, it means that sometimes, from our point of view and from a planning point of view, it means our ambulance colleagues might be on scene at the 999 call where. But for slightly longer than they were. But the trade-offs in that are exponential in terms of mainly being better for the patient because it provides the right service, but also in terms of the availability then of that ambulance to be available for the next 999 call rather than conveying the patient to hospital. So in that sense, it's a win for the patient and their family, and also it's of great benefit to the services in terms of maintaining the capacity of the service. On a continuous basis, we look at some of the patterns. We use various sources of data and information. So they might be data that's available from public health, for example, that talks about, areas of deprivation or areas of wealth or habits in terms of attendances of GPs and things. Now, obviously, we look at that information on a completely anonymized basis and on a bigger scale. But by looking at emergency attendances, 999 calls, all the sort of things you can imagine we have access to in terms of health service data and referrals from GPs and referrals to specialties. And we glue all those together and try and design services around the information, of course, taking into account patient feedback and patient stories and quality stories via conversations such as the one we're having now. And one of the services that's helped us to develop is around same-day urgent care. And again, the idea of same-day urgent care is that you see whichever clinician is most appropriate, and that those services rapidly bring you to the diagnostics or the opinions that you need. And so whereas in years gone by, you might have waited for a scan or for a diagnostic or for a result or for a different opinion, the idea is that we glue all those processes and deliver them in a way that means that the patient receives those in the day, and then the aim for most patients is to get them home, sometimes with enhanced support. And so that means that, again, it's better for the patient because they're not in hospital, but it also means that our bed acute services can be maintained for those patients who do need a hospital stay. Virtual wards. So these are a newer development as well. So virtual wards are what they say. So they are linked to acute care and they're an alternative to hospital. Once patients are identified, and at the moment our model is that those patients are identified via an assessment at the hospital, one of our hospitals, I should say. And that means that our acute care colleagues, in partnership with community colleagues and also using technology that might monitor something like heart rate or might monitor something like the oxygen level, where you put the pulse oximeter peg probe on people's fingers, that kind of thing, or blood sugar levels and things, with using a combination of additional resources in terms of people going into either someone's home or wherever they normally reside, using that clinical expertise and using that technology in the specialties of cardiology, diagnostics, frailty, end-of-life care and respiratory. It means that we've been able to provide a new sector of care, if you like, that means you are still getting acute care or care led by an acute team, but in your own home. And some of the benefits of that are listed down the right-hand side of that slide in terms of they reduce the need for hospital admissions, or they can reduce the length of stay of a hospital admission. And so far, the feedback from patients has been good in terms of their experiences of the service. And the outcomes have been good as well. And obviously it's early days, and so as we gradually build up a picture of those outcomes and those experience, we can tweak services and learn lessons and sort of iteratively modify and add quality as we go along. And obviously that's a significant boost to the capacity of the system, and by enabling virtual wards, that should release some of that pressure point that we see at our front door and in our acute services. We've also implemented a system coordination centre, and so that more obviously, over time, partner organisations have worked closely together and continue to work closely together. What the system coordination centre does, it brings that on a more formal footing, so that our different types of organisation, including our colleagues in social care and other sectors and the health sector, it sort of more formally brings together a hub and spoke type arrangement, so that those services are coordinated, not their internal coordination, but their outputs, their capacity, their demand, their pressures, they're coordinated via the system control centre, so it's system coordination centre, I'm sorry, and that provides cover over from 8 till 6, 7 days a week. Those hours also enable planning into the evening. So the impacts of the SCC, as we call it, are felt beyond 6 o'clock, because by that time of day, for many of our services, the picture has emerged, and it's about navigating that day and supporting organisations to navigate that day. But it also means by that evening time, you've got a plan going into the evening as to how organisations are going to respond, and where partners can work together to either alleviate pressure, reduce delays, maintain safety, and the like. And so the SCC, in a sense, formalizes and brings additional rigor to things that probably happened before, but less formally. And hopefully it also means that things happen on a more proactive, planned basis rather than on a reactive basis, where sometimes when you leave things to be done reactively, it means that your options are far fewer than if an issue is dealt with earlier on before it escalates too far. We're really pleased to report, so our colleagues at NHS England at a regional level have done a sort of lines of inquiry into system control centres. Each integrated care board area has a system control centre, and we were pleased and grateful that our colleagues at NHS England came to do a keen line of inquiry and actually gave the Derbyshire System Control Centre a really good feedback in terms of its level of maturity and its systems and processes that we've got in place. And I think more than that, it's delivered by a really enthusiastic team who are building the confidence of their partners in terms of the role that the SCC plays. And so no surprises probably with my final slide. And obviously, all of this does come with an ask to our population, and that is around some of the themes that I've touched on already during this slide deck. So please, yourself and by influencing others, make sure that you get vaccinated for seasonal influenza and for COVID. Obviously, it goes without saying, if you've got any concerns or you even think there's a suggestion that those vaccinations aren't appropriate for you, it's really important to discuss that with your GP or other specialist or team clinician, whether it might be a midwife, for example, or a specialist nurse who's looking after you. If you've got any doubt at all, we're putting out lots of messages, because for most people it's the right thing to do, and it keeps people safe and it reduces pressure on systems. But obviously, if you've got any concerns about that, any health professional is more than happy to give you some guidance around whether a vaccine is suitable for you or not. Please ensure that children in your families, again with the same caveats that I've just mentioned, accept the childhood series of vaccinations. Please utilise local pharmacy services that are able, as we've said, to diagnose and treat some of the more common, what we would know as high volume conditions that we see in primary care. If you think you need to go to A&E, if you're absolutely certain that you're experiencing a life-threatening or significant emergency, please dial 999. If you're less sure, then please dial 111. It's really important to say that 111, the way 111 works, is that very early in their set of questions and conversation with service use, with patients that use that service, they identify very early in their conversation with you whether they think a 999 response would be more appropriate, and then again they can seamlessly talk through and put calls through to 999, whichever is more appropriate, so that doesn't involve patients being A, inconvenienced, and B, their safety being compromised by having to make an additional call. That those calls can be put straight through. And also, please keep an eye out on local media, whether that be the local TV news, local radio news. I'm sure Mark will explain better than me, but there are various social media channels that the Integrated Care Board run, or the different health and social care organisations in Derbyshire run, and there's information available on there as well. Often the websites of our health and social care providers, they have information that's helpful fairly early, within 1 or 2 clicks when going onto their website. So thank you. It's impossible to discuss everything in detail, obviously, because, as we said, urgent and emergency care, to a greater or lesser extent, touches on and catches most services that we offer. But I hope that's been a useful fly through some of the services that are available and some of the work that is ongoing in terms of trying to develop the system. Thanks, Mark.
Thank you very much for that, Andrew. That was a great presentation, and I think my 2 takeaways for that would be the essential and sometimes underused role of the pharmacies. They're so useful, especially for those lower level things. I'm also very excited about all the work with virtual wards as well. They're going to be a game changer. So we have some things in the chat for you, Andrew. First of all, there's just an observation from Pete Steedman. He says the opportunity for NHS 111 to facilitate appointments at UTCs is not well known. He's personally used this treatment route and was seen immediately when he presented at the UTC, but the waiting time, if he had arrived without contacting NHS 111, would have been considerable. So the message there is, do contact 111, make that appointment rather than just rocking up, even though you can just rock up. Next, we've got Kay Bagley. She has an observation that pharmacists seem to be very overstretched. And they seem to struggle with all the things they now have to juggle, including vaccinations. So thank you for that, Kay. And Kay also would like paper copies of the UEC. Is that something I can work with you, Andrew, to get hold of?
Yeah, we probably need to go back to Kay maybe outside the meeting and just clarify which papers and information you're interested in, Kay, if that's okay.
Yeah, I've given her the email address in the chat, so we can do that after. So Kay has a question. She says, do you have close links with the ambulance services? How do you make sure rural areas have equal support to ambulances in an emergency to that of the inner city and urban areas, and ensure response times remain?
The answer is yes. It's in terms of the Integrated Care Board. It's actually one of my colleagues who links closely with the ambulance service in terms of their contracting and performance arrangements. But yes, ambulance service colleagues in an area like Derbyshire, of course, do acknowledge that planning means that we've got areas of of significant urbanisation, but also areas of significant rurality. Obviously, they also use mechanisms and support from our voluntary colleagues in terms of community responders, and so they do their planning and locate their vehicles and their resources in a way that sort of is agile and best meets the call pattern at any one time. It's fair to say that sometimes managing services in ruralities isn't without its challenges, and of course we recognise that. But yes, our ambulance service colleagues do plan and take into account that some of our areas are extremely rural.
Okay, we've got a question from Pete Steedman. An impression often highlighted in the media is that a significant proportion of those presenting at A&E should have used an alternative service, i.e. their issue was not life-threatening. Does your analysis data support this impression? And if so, what are the primary causes of the public accessing A&E inappropriately?
So yes, so it's always important to say that there is a difference between looking at information of the patient's condition with the hindsight of having a thorough assessment compared with before the patient's had that thorough assessment. And so those two things are different, because obviously once someone's had a senior medical opinion and potentially some diagnostic tests run, it becomes apparent that they can be reassured that perhaps their care that they had less of a problem than perhaps they feared they had, or that their care could have been provided somewhere else. But notwithstanding that, it is clear that some of the presentations that come to the emergency departments could be dealt with more effectively or more quickly at an alternative location, and that could be, depending on the presentation, it could be any of the it could be one or several of the locations that I've mentioned already today, in terms of pharmacies, urgent treatment centres, or indeed contacting your own GP. We should never forget that our colleagues in primary care, our GP surgeries and their teams also have access to urgent appointments and see a huge number of patients that have urgent needs.
Awesome. One of the things I've noticed that we get in Derbyshire Dialogue is that people tend to link up services while we're here, so it serves another function as well. Helen Hall has said that she works for the Derbyshire Home from Hospital Service, would be interested in linking with the System Coordination Centre if possible. So is that something where we could facilitate that if she sends in her email address?
Yeah, by all means do that, and we'll point Helen to the right colleagues. Thank you, Helen.
Awesome. Helen, just email me at ddicb.inquiries@nhs.net and I'll make sure that happens. So we have a question from Ken Davis. How do we look after people who have no internet or digital access?
I think that's a really good point, and it's important to keep open those channels that we that aren't digital in that respect. And so for 111, that's why I was keen to sort of say that the telephony service is available. I think most people probably still contact their own GP via a landline or a mobile call, but a non-online method. Obviously, in terms of 999 services, they're non-digital, and I think we continue to have what you might call more traditional information sets in GPs and in hospitals and in various health and social care settings, in council offices and other community resource centres. But maybe we need to look at that again in terms of that information on a page or on a poster, if you like, to make sure that the information that we've purveyed in this presentation is available for people to pick up and collect from their local information point, whether that be in supermarkets, community centres, places of worship and the like. It's a good point.
Okay, we have one more from the chat before we go to a couple of hands up. So Simon Ratcliffe asks, do any medical treatment notes from UTC or EMAS go to the general practice? And also winter vaccine newsletter. Oh, it's a separate question. We'll do that one first, if you don't mind. So medical treatment notes from UTC or EMAS, do they go to the general practice?
They do. A summary of the care record and the outcome of that care record does go to the general practice, yes.
Okay. And his other question was, winter vaccine newsletter is not in easy read under accessible information standards. So is that something perhaps we're going to do something about?
I think you and I should look at that, Mark, and take that away. And again, thank you for raising that point.
Excellent. Okay, so we have some hands up. So Pete Steedman.
Yes, thanks, Stuart. Yeah, good afternoon, Andrew. I just really wanted to come back on your response to my question that Stuart alluded to earlier, and thanks for your information there. The thing that really is sort of concerning me is, have we actually got any hard data which we've analysed, which actually indicates why people attend A&E when clearly they should have been going to another service? I do accept what you said in your answer, but there are obviously situations where people are presenting in the wrong environment there, i.e. A&E. And if that is the case, what is the sort of the root causes of why people are attending A&E? Is it through ignorance, the fact that they don't know that there are UTCs available, for example, or is it lack of confidence that other areas of the healthcare system they feel don't give them the confidence that they will get the support they would get from A&E?
So, Peter, I'll get back to you on that if I may. I'm only actually three weeks into post, and so unfortunately I don't have readily to hand a specific Derbyshire answer to that in terms of what we might call attitudinal studies, I guess, in terms of patients who've accessed ED when perhaps they could have gone to other services. I know there are various surveys and things like that that colleagues have done in different areas, or sometimes other organisations such as Royal Colleges might look at that type of thing in terms of patient attitude and things. It's obviously, one of the things is that A&E, as it was called, ED as it is called, is a very trusted brand in terms of most of us on this call could be driving anywhere in the country, and if we see that little red sign on a roundabout or on a road sign, we know what we can expect, and it is difficult to that recognition of that. And let's be really clear, that's a good thing, because it means that if people are in trouble or have a genuine emergency, it means that anywhere in the country they know what they're looking for and they know where to head. And so it's really important to keep that message current and not do anything that diminishes that, but at the same time increase the profile of those other services. In terms of your specific question for Derbyshire and patient attitudes and things, I'll get back to you with whatever information I can. I'm sorry I can't answer that more comprehensively on the call.
Yeah, Pete, what will happen is at the end of this session, the Q&A, I'll create that as I always do. It may be posted onto the engagement platform probably tomorrow. So it will have a holding answer based on what Andrew's already said in there, and then I'll update that document. It sounds like something where it may take a few days in order to get a comprehensive answer, but that will be updated as soon as we have it as well. Is that okay?
That's absolutely brilliant. Thanks, Andrew. Fully understanding. Yeah, great. Thanks, Stuart.
Okay, it's Aaron Johnson next, please.
Yeah, thank you. So it's just to come in on Ken's point around digital and access to digital. So what we did through our public health locality, we've got quite a lot pockets of community that are digitally excluded, and working through with our place lines and ICB and the PCNs, it was coming forward through surveys that they did that a lot of their patients didn't know how to access the NHS app through the digital platform. So what we did and working with our voluntary community sector is about shaping that locally. So what fits locally for our communities, and so part of that digital project was to work with the PCNs, and so that they could then, their patients could then access that digital NHS app. So it was about around educating them. Some of them obviously didn't have devices, so there was opportunities then to gift devices as well, so they could access it. So I suppose it's around looking at the data locally around your digital exclusion in your area, and if you can link into your public health locality funding, is to shape that delivery locally around digital exclusion and what fits to help obviously reduce the pressures on the NHS. If we can educate that cohort of people digitally and give them devices as well, so that might be worth something to consider for you, Ken.
And I think we may be there. Does anybody else have any last question?
Mark, just to say, if I may, what we alluded to at the beginning, every healthcare system has what we call a winter wash up that normally happens sometime in the spring, where we review how our planning processes for the winter months went, whether our predictions and our forecasts and things were reasonably accurate, and how services responded, and what went well and what we could have done better. Mark and I will discuss that we'd like to involve patients in those conversations, and so please take this as a commitment that, as I'm not quite sure what that will look like, but whether it's a session like this or another way of communicating, we'll ensure that the voices on this call and other voices are an important part of that winter wash up in terms of patients' individual stories and experiences.
In that case, sorry, I was on silent there. In that case, what I'll do is I'll bring this session to a close. So first of all, thank you very much to Andrew Side, both of them. That was really a great presentation, highlighted the various services involved. Also like to thank the BSL interpreters, both Helen and Maria. Great effort as always. Mostly I'd like to thank everybody that has attended the session. We put these sessions on for you, and you make the sessions, and your contribution to these sessions also helps shape services and make things better. And finally, I just want to make you aware of the next session, which is on the 11th of December. I'll send out an invite for that almost immediately after this session, and that's going to be on GP access. So that's everything to do with how many GPs we have, how many appointments we have, and why sometimes you may have difficulty getting to one of those appointments. So there's something in there for everybody. So thank you very much everybody for attending today, and hopefully we'll see you in December. Thank you very much. Bye-bye.
Thank you.